Hello, welcome back to HeartBrief. I'm Joel Kahn, medical doctor, triple board certified preventive cardiologist with a clinic in Detroit and in Boca Raton, Florida. So let's dig into three really interesting articles this week that I think will be of use for you in your own practice, maybe even in your own life, particularly if you're an athlete. So maybe we will start with that one. See if I'm doing this well. Good for me. This is from the European Society of Cardiology and the American College of Cardiology, a joint publication just out in the journal American College of Cardiology. I think you can see it. Masters athletes with abnormal cardiovascular findings. This is a long and important article. They got a lot of press because it's such an important and unexpected topic. And they go through number one, what is a master's athlete? Over age 35, exercise training volumes higher than usual, improving fitness and performance goals driven by performance goals. And they looked at different areas of cardiovascular function: arrhythmia, coronary atherosclerosis, aortic dilation, myocardial fibrosis, and exercise induced arrhythmogenic cardiomyopathy. And they provided perspectives here on the frequency, which is distressingly present in masters athletes, even with no complaints of reduced exercise capacity. And athletes often don't want to take medication should they be found to have a dilated left ventricle or dilated aorta, as an example. They have a lot of data because they often wear wearables like the Apple Watch, and they have to be included in the decision. For many of them, this athletic activity is so important to their very being. So they go through a variety of cardiovascular conditions here, like atrial fibrillation, and the idea that this needs to be monitored for, needs to be discussed as a risk, whether due to a standard risk factor like hypertension, obstructive sleep apnea, obesity, alcohol, and hyperthyroidism, or whether uniquely due to their accelerated endurance exercise. They go through bradyarrhythmia because so many of these athletes have heart rates in the high 30s without symptoms. But if they're symptomatic, it's going to require some evaluation. Ventricular arrhythmias, should they be wearing monitors during exercise or in a prolonged period, or using their wearables more definitively? And they do show that the higher the amount of exercise, particularly if a calcium score is obtained and is elevated, the higher is the risk. So, a very important article that I think everybody should focus on either for their own physical activity or for advising on patients. And it certainly isn't a call to stop exercising. It does raise the question to some extent. Is it necessary to do, 300 minutes a week or more of intense exercise like many masters athletes do? I have many of them in my clinic. I'm not one. I'm very happy to get my 75 minutes a week of vigorous or 150 minutes a week of moderate intensity exercise, split between cardio, balance, yoga, and strength. But bully for those that do more, they just need to be monitored. Okay. So we are going to go back to a second article and let's see how this plays out. Um, yeah, it's what I wanted. Okay. It's kind of a funky one, and there is a twist here, but a good journal, Journal of the American Heart Association, effective increasing total fruit intake with avocado and mango on endothelial function and cardiometabolic risk factors in adults with prediabetes. Lead author Chelsea Brace, and this was just published in April of 2026. So what they did here is they took one avocado and 1 cup of mango for 8 weeks. They did baseline flow mediated vasodilatation in a group of volunteers with prediabetes. They did follow up post treatment flow mediated dilatation, a marker used more in a research mode than in the clinic of vascular function, endothelial function. And they also looked at metabolic measures. They made the point that low fruit intake is among the top 3 dietary risk factors contributing to cardiovascular disease. And sometimes fruit gets a bad rap. And as you know, avocado technically is a fruit. And what they did identify in this group, where there was a control group, 41 people, and the avocado mango group, 41 people, is that flow-mediated dilatation endothelial function improved right there. You can see it, that there was a big jump in vascular function. And when they looked at, was there any deterioration, cardiometabolic markers in glycemia, lipids, inflammation markers, and the rest, they actually went in a positive direction on the control group. And then overall, there's very trivial change in weight. So it's, in general, an article that has us re-examine the idea that fruit should be avoided in prediabetes, whole fruit, not fruit juice, not gummies. I recommend fruit to my patients all the time. I will have you notice that under sources of funding, the avocado board and the mango board did fund this study. So that, has to be identified as an issue as you're evaluating it. Although, of course, the authors would indicate they were not influenced by the funding. And finally, last article of this week. Let me get to it because it is important. Here we go. Good job. In the journal BMC Cardiovascular Disorders, lead author Laura Naha, sleep timing irregularity in midlife, association with incident major adverse cardiac events and cardiovascular disease mortality over 10 years. And this was a study of 3,231 people in northern Finland who had long-term follow-up in a research study, but they knew from a 7-day standard evaluation if they went to bed at about the same time every day, if they went to bed at variable times every day, was their sleep duration fairly set day to day, was it irregular day to day? And this was separate from the diagnosis of sleep apnea. This was sleep irregularity. And a number of these people, 4% of them, had a cardiac event during follow-up. Irregular sleep timing was associated with an elevated risk, but this was observed only among participants whose sleep method was shorter than the group median. So if you're going to bed at variable times and averaging overall shorter than average sleep, let's say less than 7.5 hours at night, you are particularly at risk, 2 times the risk. 2 times the risk is like a smoking risk if this were to be verified in other studies. So asking your patient about time in bed, time up, how many times up to use the restroom, snoring, stopping breathing. So many of my patients, the partner sleeps down the hall. One of them snores, or one of them's restless, or there's a dog involved or something. But focusing on sleep, knowing that now there's such easy availability of home sleep studies at a very low cost and high accuracy, we can really up the game for meaningful sleep consultation with patients, no matter what our specialty. So that is HeartBrief this week. I'm Joel Kahn, medical doctor, preventive cardiologist. Thank you for being here. We'll come back with 3 great articles next week. Thank you.